Thank you, John, and thank you, everybody. This morning's speaker, Dr. Bob Slama, and I have been close personal friends for over 30 years, he and his wife, Sharon. And Bob was my personal cardiologist for a good chunk of that time until I reached a point where my insurance coverage was not covered by the then at the time Summit Medical Group, so I had to move on. Bob is a very excellent doctor. He describes himself regarding his current involvement in medicine as 3/4 retired. Nevertheless, he is active on the bioethics committee at Overlook and Morristown hospitals. And when I asked him if he would consider speaking this morning, he said very quickly, I would like to do that. So it is my pleasure to introduce my friend, Dr. Bob Slama, to the Summit Old Guard. Bob, take it away.
Let me go. Victor, thanks very much. And it's a pleasure to be here with the Old Guard, a group that I've known for a long time in terms of many of your members. Let me see here. So we're going to go over a bunch of things and, starting in the old days, so to speak, and certainly coming up to more modern times. And we'll have a little bit of time, I think, to talk about some of the future, although that's a little harder to talk about. But I want to, first of all, kind of just give you a little background. I finished my cardiology training in 1976, and I had some obligated service in the Air Force, and then I was at Walter Reed for 2 years. But I had the great pleasure of being able to join the Summit Medical Group in 1980 and joined two other cardiologists, Tom Inglesby and Greg Sachs. And the reason I ended up being happy to come to, not only was Summit a wonderful town, but the idea of having a multi-specialty practice of medicine with other internists, subspecialists, surgeons, all in one group, all with each patient having their own individual medical chart, was somewhat unique. Certainly in the East Coast, it was much more common, as you probably know, in the Midwest with places like the Mayo Clinic. But the Summit Medical Group was started in the 1920s and has grown since then. Now, a lot of you know we're not anymore the Summit Medical Group. Now we are Summit Health, and there was a merger actually about 3 years ago of Summit Health and CityMD. So that now instead of 50 providers or doctors, there are about 2,500. There are, I think, 12 or 13,000 employees. We have urgent care centers in about 150 places, predominantly in the New York, Long Island, New Jersey, even now, southern New Jersey. And there's a recent addition of the New Jersey Urology Group, which is an incredibly large and very well-respected group of urologists in New Jersey, and WestMed, which is a fairly large multi-specialty group in the Westchester area. And also we are connected with a group in Oregon also. But let me go sort of the beginning part of this is, quote, yesterday or the early days of myocardial infarction. And obviously you recognize the face. This is President Eisenhower. He and his wife, Mamie, had been on a vacation, a work-play vacation in the Denver area with plan to be there for 2 months or so. And in the middle of September, or somewhat later in September, he was playing golf and apparently had some symptoms of indigestion. He didn't seem to make too much of it, but then later that night, around 2 a.m, he had chest discomfort. Mamie apparently helped to get the doctor to come in to see the president. And he actually was treated initially staying at the resort place that they were with morphine, which he got throughout the night, apparently. It wasn't until the next day, Saturday afternoon around 1 o'clock, when the doctor ended up doing an EKG, and lo and behold, they found that he had or was in the process of having a large anterior wall myocardial infarction. He was taken not by ambulance, but by Secret Service to the local Army hospital, Fitzsimmons Army Hospital, and was in the hospital for roughly a month. This is when he made his first public appearance, about 1 month later, and it was just about that time that he was discharged to home. There wasn't much that people did in terms of active treatment for myocardial infarction back in the 1955 timeframe. And in fact, the president ended up surviving this heart attack, but 14 years later, ended up having what we call ischemic cardiomyopathy, where his heart had enlarged and was severely weakened from multiple prior heart attacks, so that the ejection fraction was low and he wasn't able to survive that. He died at age 78. The mortality for President Eisenhower in that time frame was, for an acute myocardial infarction, was around 40%. In the slide, I think you can see on this slide on the graph on the right, it started to get a little bit better. The mortality for heart attacks in the 1960s was around 30%. In the 1970s, more in the 20% range, and then in the 1980s, down in the 15 to 20% range. So there was some improvement. But what is it that causes a heart attack? You may have seen on the headline here, coronary thrombosis, and it's a term that has been used off and on for over 100 years. It was originally described in the initial description of heart attack by Dr. James Herrick in 1912. And he suspected, even though he couldn't prove it, that coronary thrombosis was the problem that caused the actual acute heart attack. Even when I was in medical school, it was still talked about, but never proven, because at autopsy, when the pathologist would end up doing an autopsy on people that died within the first day or two or three of a heart attack, they very often did not see any evidence of thrombus in the coronary artery. Maybe 60% of the time they would, but 40% of the time they wouldn't. So there was great uncertainty even into the 1960s and 70s as to the actual cause of the acute heart attack. In 1980, a rather dramatic study was done that was considered, again, quite adventurous. The group in Seattle, led by Dr. Marcus Wood, ended up taking people that were coming into the emergency room with this beginning of a heart attack. They were taking them directly to the cath lab and doing a coronary angiogram. That was considered pretty wild and crazy back in those days. For one thing, cath labs had kind of banker's hours. They were open from 9 to 5 maybe, but certainly if you came into the hospital at 10 o'clock at night, you weren't going to get in the cath lab. But they ended up being able to go ahead and take people directly in the early hours of a heart attack. And what they found was, in a way, answered the question of coronary thrombus. They found that about 90% of people in the beginning of a heart attack had a thrombus. And if you looked several hours later, like 4, 5, 6 hours after the beginning of a heart attack, it had already gone down to maybe 60%. So the cause of acute heart attack, what we call ST segment elevation heart attack, was basically established in 1980 as being due to thrombus. That led to the next part of treatment of heart attack. Here's an EKG that shows the normal ST segment here on the left and the ST segment elevation on the EKG on the right, which is virtually diagnostic of an acute heart attack. So in the early days, in the 1980s and early 1990s, thrombolytic therapy was the primary option. And if you ended up on the left part of the graph here, if people were treated within the first several hours, specifically under 2 hours from the time of their chest pain or onset of their heart attack, there was a pretty dramatic improvement in terms of the mortality rate. Those that had thrombolytic therapy in the black bar and those that did not have thrombolytic therapy with the striped bar. However, once you got out farther, 4 hours, 5 hours, 6 hours after the onset of the heart attack, there was no benefit to thrombolytic therapy. The second thing about thrombolytic therapy is that it brought a new series of problems. Thrombolytic therapy not only dissolved the clot in the coronary artery, but it also made people very likely to have intracranial hemorrhage, so that people, especially older people over 60 or 65, were more likely to have stroke, and either fatal stroke or dying from some other cause. So the benefit of thrombolytic therapy was not that great, certainly not good for people in the older age bracket. Somewhat, I'll say, across the continent or across the ocean, a revolution was somewhat starting. We didn't really know it, but this is Dr. Andreas Grunzig, and this is kind of a sketchy picture from his poster presentation at the American Heart Association meeting in 1976 in Miami. So this was hardly big glamour or something that got any attention. This was kind of in the back room of this large convention hall. But he was able to show and then publish in 1979 that if you had people that had, in this case, not a heart attack, but had severe coronary blockage that was causing angina chest pain, and that they were candidates to have single vessel bypass surgery or 1 or 2 vessel bypass surgery, they could go ahead and put a balloon catheter in, inflate the balloon, and open up the blockage. Here, it's a little hard to see here. I think maybe the next slide shows it better. This was a revolutionary idea, and again, some of the people that were leading the charge at that time have to be considered the people that foresaw all the great leaps over the next 40 or 50 years. Unfortunately, Dr. Grunzig and his wife died in a plane crash. He was 46 at the time of the plane crash, and he was flying the plane they were flying back from the St. Simon Island, that area down in Georgia, he was working in Atlanta at Emory at the time. And I guess my only comment would be, I can tell you from numerous personal examples that doctors don't make good pilots. So I guess from your talk several weeks ago, I admire the people that can fly planes, but I wouldn't pick cardiologists or other doctors based on my experience from either classmates in medical school or other people that I've known that have been doctors and have had either fatal plane crashes or very serious plane crashes. So initially, like I said, in the 1980s, we used thrombolytic therapy. The TIMI trial was one that proved that thrombolytic therapy was effective. But then by 1993, the superiority of primary angioplasty, PCI, is percutaneous coronary intervention or angioplasty, that there was clearly a benefit doing acute primary angioplasty as opposed to thrombolytic therapy. So for the next 20 years plus, in fact, it's obviously till today, it's almost 30 years. Angioplasty has been the primary way to treat acute myocardial infarction. Now I'm going to give you an example of somebody, this is from February, a woman in one of the nearby towns had never had any heart trouble, but she had well-established diabetes and hypertension, was on medicines for each of those problems, had been intolerant of statins. It was somewhat referred to as an allergy to statins, but she was intolerant of statins. And lo and behold, in the middle of February this year, she started having some chest pain symptoms at home. And by 11:30 at night, they became apparently much, much worse. And she finally kind of told her family, called 911. Calling 911 is one of these things that I want to be kind of a take-home message. Just remember, that's what you need to do. The EMS team arrived at her house within 5 or 10 minutes, and they were able to do a remote EKG and transmit it to, in this case, Overlook Hospital, where the ER doctor was the quote, control doctor. And the EKG showed ST elevation in the inferior leads. So that enabled, even shortly after the EMS people arrived at her house, they were able to notify, and the ER doctor was able to start what is referred to as code STEMI team. That involves calling in the people from the cath lab to come from their home, the on-call cardiology doctor, who is the interventional doctor, and they were able to arrive promptly. Now here's the actual EKG of this woman. You can see the ST elevation. These are the quote inferior leads that tell us that the heart attack involves the bottom wall of the heart. Dr. Nick Giuliano was the cardiologist on call that night, and he ended up sharing these pictures with me. He was able to see this woman because he'd been notified by the ER right around midnight. He was able to see her in the emergency room, explain to the patient and her husband what was going on, and take her to the cath lab.
Call from.
The phones don't stop, right? And lo and behold, in the cath lab, the right coronary angiogram shows that it's the right coronary artery that starts right here is totally blocked, probably 2 centimeters after the origin of the right coronary artery. As you might notice from the time, this is literally less than an hour after she had arrived in the emergency room. The next set of pictures is the left coronary artery, which is standard in this type of procedure to make sure there are not any other critical blockages. This woman has fairly severe blockage in her left circumflex and also multiple 70% blockages in her left anterior descending coronary artery. Here's Dr. Giuliano now doing initial trying to get the vessel open with an atherectomy catheter. And that ended up, the next set of pictures here show that they're now, even just with the atherectomy catheter, even though there's still a severe narrowing right there, there is flow, antegrade blood flow through the coronary artery so that you're starting to get blood supply to this bottom wall here. And with that improvement, even relatively slight improvement in blood flow, this woman had improvement not only in chest pain, but also in her heart rhythm. She had had what we call heart block, AV, electrical heart block, which improved after they were able to get this artery somewhat open. I'm going to go through this next part fairly fast, but she required multiple stents, one stent here and then a second stent kind of down in this area. And these are drug-eluting stents. And here's kind of a before and after. This is the picture I originally showed you, and this is the result after the multiple stents and all the other work that was done. Dramatically improved flow here on the bottom wall of the heart. This is a picture of the right coronary looking from the opposite direction. And this is called an LV-gram, left ventriculogram, and it shows the heart muscle contracting. And if she had not had this angioplasty, this whole bottom wall here would not be moving at all. It would have the beginning of scar damage. So to summarize, we have in 1955, that era, 40% mortality from acute MI. And today, the overall mortality for STEMI is in the 4 to 7% range. Typically, if we can get people in the hospital fast with the door to balloon time under an hour and a half, they do very well. This particular woman, the door to balloon time, that's from the door coming in the emergency room to the time that they're able to inflate the balloon in the cath lab, was 75 minutes. She was able to be discharged 2 days after coming in the hospital, as opposed to the 1 month or more that President Eisenhower had. So again, I'm going to sort of say, remember this 911. That's one of the key messages here. And the door to balloon time is something that we keep track of all throughout the country, but certainly in New Jersey. This diagram talks here about PCI capable. In New Jersey, there are 45 hospitals that can do acute angioplasty. So virtually everybody in New Jersey goes to this part of the algorithm. The not PCI capable would be more typical, where thrombolysis might still be used. If people in Montana or Texas or someplace where they can't get to a PCI hospital, they might initially get thrombolytic therapy and then get a subsequent angioplasty if needed. Here again, you can see the mortality at 30 days if you get the angioplasty done in under 90 minutes. All this group, these 3 bars to the left, you can see the mortality at 30 days is in the 3 to 4% range. And yes, New Jersey keeps track of this. In 2019, there were about 3,687 angioplasties done for acute heart attack, STEMI infarcts, at 45 hospitals. And the state keeps very active records as to how each hospital is performing in terms of getting people promptly into the cath lab and getting the balloon inflated. And in the current numbers, and this has been true for many years, but especially in the past 5 years, the door to balloon time under 90 minutes is 84% of patients. Pretty impressive. There are actually a total of 25, just as a typical year, 25,000 angioplasties done in New Jersey, so that the acute angioplasty, primary angioplasty for a heart attack, represents about 1 out of 10 or 1 out of 9 of the total angioplasties done in the state. For those who remember just from 2020, especially in the early part of COVID, there was a tremendous change in terms of admissions to the hospital, and the total number of cases in 2020 that had acute angioplasty for STEMI had dropped about 11%. So I want to show just a couple pictures not to try to rival my friend Victor, but to there's just some things I want to mention that come from France. So it reminded me to get out some slides from 1966 when I was in college between my junior and senior year, and a bunch of us were in Europe making the tour. And I guess I would say one of the comparisons is some of you may remember the book Europe won $10 a day. I think initially the first book was Europe won $5 a day, but when I was there, they said it was Europe won $10 a day. It's gone up a lot since then, I'll tell you that. But part of the reason for talking about France is that they have some very good data comparing the change in mortality from STEMI. This is a 6-month mortality data. It's a little hard to see this. This is 1995, 2000, 2005, 2010, and then over here on the right, 2015. You can see the mortality has come down for the angioplasty group, the reperfusion group, from 11% to 9% to 6.5%, down to 4.8% over those 25 years. Even people that don't have reperfusion, don't have angioplasty or thrombolytic therapy, quote, medical therapy for heart attack, even for those without acute angioplasty, has improved a lot. And the other part that I want to say is that we have a lot to be thankful for, a lot to be proud of in terms of lower mortality rates from coronary heart disease. In the United States, if you look since 1968, there has been a 75% drop in the death rate due to coronary heart disease. This particular graph only goes to 1998, but basically has continued since then up to 2022. Not quite as dramatically down, but nevertheless, it continues to look good. This is the United States here with the blue bar in terms of coronary death rates. We're good, but we're not as good as Australia or Germany or Sweden. And again, this is males on the left and females on the right. The other thing that I know you're all interested in is how about as I get older, how much more of a risk is it? Well, coronary disease definitely is very age related. So that here at 65 to 74 age bracket, it already has started to jump up. And by the time you get over here on the right with people over in their 85 or over 95, you're up in the 30% range, 31% that have coronary disease, either prior heart attack or angina. And again, this shows somewhat by age. And the main thing I want to show here is that men, I'll say, peak early in the 65 to 75 age bracket. The red bars are women. And women, unfortunately for them, once menopause occurs, let's say when women are 50, by the time they're in their 60s or 70s, they have really started to catch up and literally go ahead of men in terms of the rate of coronary trouble when they're up in their 80s and 90s. There has been a general decline, and the graph on the right is STEMI infarction, but all infarctions have been favorably gone down compared to 2000 and 2014. This is also, in this particular slide, looks at both ethnic groups, Hispanic, Asian, Pacific Island, Black, white, all have had a very favorable drop in terms of the frequency of infarction. So why are we having these better results? Well, there are probably a bunch of things that we need to give tribute to. This is what is referred by the American Heart Association as the simple sevens, life's simple seven. I wish it was so simple, but here's some of the ones that you know are no good. We'll talk about cigarettes, exercise. This is weight control. Diet here, carrots, apples, fish. Blood sugar here, cholesterol, HDL, LDL, and blood pressure, hypertension. All are very important. I'm going to concentrate on a few of them, and I'm afraid I'm not going to talk about diet quite as much. This is probably not a group that I need to spend too much time on this, but cigarette smoking has gone down a lot, down 66% over the past 55, 60 years. And it currently, in the most recent measure in this is 2018, not 1918. The number has gone down to 13.7% of people smoking. So the graph here shows male percentage of smokers. This is 1995 on the right part of the graph, but it's gone down even further since this end of this graph, down to 13.7% for men and women together. This is somewhat complicated, and I don't want to get into all the details, but this is looking at ideal health, the 7 things that I just mentioned: cigarettes, obesity, diet, physical activity, blood pressure, hypertension, diabetes, and cholesterol levels. If you take ideal 5 out of 7, how many people do you think would get 5 of these ideal categories out of the 7? It turns out to be related to 2 things. One is income, family income. The lower end of the income level, these are basically people under the poverty level, probably with incomes in the $40,000 range. This blue box here is not only lower income, but also high school education, or actually, I'm sorry, less than high school education. High school graduate is here in the red bar. And you can see as the high school graduates have, quote, higher incomes, they start having, well, in this case, their behaviors are worse. But for the people that are not high school graduates, they have more good health, ideal health criteria as they get better off economically. And also, if you take college graduates, you can see up in the 25, 30% of people have the 5 of the 7 ideal health attributes. The next thing that we haven't done, we talked about cigarettes being a good story. Cigarette smoking has gone down a lot. Obesity has continued to go up. This shows now, over the past 20 years, 30% obesity. Today, more like 42% obesity. And severe obesity has doubled from 5%, let's say, to today, right around 10%. Now, what does that mean? Severe obesity, as you probably know, the obesity index is used, the body mass index. And some of you may have already calculated yours, but just to give you an example, if you're 5 feet 9 inches, your healthy weight is in the 125 to 168 range. Your BMI is between 18 and 25. But to jump ahead, if you are over 203 pounds, your BMI now is greater than 30 and you are officially obese. If you go even farther and you have a weight of, again, 5'9", a weight of 271, you are now have a BMI 40 or higher, and you are severely obese, class 3 obesity. Again, aerobic activity and obesity are related to the level of educational attainment. Better educated 4-year college advanced degree are more likely to be active. This is not even talking about serious, heavy exercise. This is moderate activity, greater than 150 minutes a week. That's not a particularly high bar to meet, but nevertheless, it's the numbers are what they are. Now, I'm going to spend a fair amount of time over the next couple minutes talking about cholesterol, and there have been some phenomenal workers and research done, Nobel Prize winners, not only these four men that were awarded in 1902 and 64 and 2 and 85, but also 9 others over the past 100 years that have received Nobel Prizes for cholesterol research of some sort. So here is the coronary plaque. And to go back a little bit to some of the basics, if you take people that are killed in Vietnam or killed in Iraq, American GIs in their 20s or 30s, many of them have fatty streaks. This is an early form of atherosclerosis. You can create this same type of fatty streak in an animal experiment. For instance, if you give monkeys I'll say an American diet, McDonald's type American diet, the monkeys develop fatty streaks within several months. And the good news is that you can get plaque regression in these monkeys. All you have to do is put them back on a regular good monkey diet and off the American diet. So we have known that in a way for lab animals for a long time, but the data is also pretty clear that even for adults, 50, 60, 70, 80 years old, they can have intermediate lesions, they can have advanced lesions like this, and there is still very good evidence that they will have regression of the plaque. Some of the studies look at what we call total atheroma volume. This involves basically doing an angiogram or putting in a special catheter to measure the amount of atheroma. And if you start over here with LDL levels in the 97 range and you compare that with lower levels of LDL down even to 58 or lower, you can see you get a fair amount of atheroma reduction, 5% or 10%. That doesn't sound like much, but in a small coronary artery, that is a lot. I always say it's a little bit like a carburetor in your car. You may not know there's a little bit of plaque in the carburetor, but your engine sure knows it. So, and another way to look at the effect of lowering cholesterol and plaque regression is that for every 38, well, let's round it off to 40 milligram per deciliter drop in LDL cholesterol, there is a 23% reduction in major vascular events. Now, again, that's the thing that is so dramatic, not only in the statin trials, which we have a lot of here, but even in the early days back 50 plus years ago, when cholesterol reduction was done sometimes with ileal bypass, very dramatic reduction of LDL. You know, LDL would go down by 60, 70, 80 points. And you can see the reduction over here on the right side of the screen. The relative risk reduction is in the 30 to 40% range. Now, let me mention a couple things about statins. First of all, the good thing, I guess, about statins is that they are the best thing we have by far. They're cheap. They're virtually all off patent. And even at a low dose, a starting dose, you get somewhere in the 38% lowering of LDL to 28%. Depends on the statin. I only showed 2 of them here. As you increase the dose of statin from 10 to 20 milligrams to 40 milligrams a day to 80 milligrams a day, you get some further lowering of LDL. But the big effect is here in the initial dose. So that's one of the reasons we sort of say, look, even if you can't take a big dose of statin, even a small dose is worthwhile. Frankly, even taking it 4 days a week is worthwhile for some people that seem to have trouble with statin muscle aches. So just again, to give you a little example, if you take the person on a starting dose of a statin, 38% reduction would be equivalent to, let me do this. Let's say you start with a very high LDL of 211. You have a 38% drop in your LDL. That means it's gone down 80 milligram per deciliter, which translates to a 46% reduction in major vascular events. That is phenomenal. There's not much we have in medicine that does that kind of bang for the buck. I'm going to skip through. This is just all the different lipid trials, but they show basically the same thing. And that is, if you, here again, if the amount of LDL reduction is 40 milligrams per deciliter, you get this much reduction in major vascular events. If you get 60 milligram or more, you get a higher amount of reduction. And especially, this slide points out that especially in studies that are done where the duration of treatment is longer, you can get even greater benefit from the treatment that you're giving. And in fact, now that we have even more advanced medicines, you can make, I'll say, a hypothetical argument that if you get people who have genotype-driven studies, that's gene testing that can be more accurate, and you can identify the right people, you may be able to have even a 50% reduction if you start treating these people at an earlier age. 50% reduction in major vascular events. Now, the next couple slides are about something that I know everybody is interested in, and I would say this is in the category of probable but not proven. Do statins lower the risk of dementia? There certainly is a lot of observational data. There are not any studies that have directly answered the question, but the answer tends to come from combining what are called meta-analysis of virtually 20 or 30 statin trials. And when they add up all these trials, over 1 million people were represented in these trials. And this line here in the middle, the one, is if no effect. So some of these studies where the little line, the dark bar and then the little line, if that overlaps the line here in the middle, that means there's no statistical difference. But you can see when they add up all these studies together, again, so-called meta-analysis, that there is a favorable impact in terms of Alzheimer's on people that are getting statins compared to no statin. Again, this is the same type of thing. This is also looking at people over 75 years of age. Again, these are observational, and frankly, you get into the whole issue of how do you compare the group getting the statin may not be identical to start with to the group not getting a statin. I mentioned briefly about the intensity of statin therapy. You can have now, for instance, for people that have had a recent heart attack or recent angioplasty, we recommend high intensity statin therapy, which would mean, for instance, Lipitor or atorvastatin, 40 milligrams or 80 milligrams, or Crestor, rosuvastatin, 20 milligrams or 40 milligrams. The other statins work also well, but these would probably be the two most common. And I'm going to mention one thing here about one of the new medicines that has come out in the past 5 years, which I'm sure you've heard about, so-called PCSK9 inhibitors. They are very effective. They are monoclonal antibodies which have to be given by injection either every 2 weeks or 4 weeks. There are some new versions that probably will, that don't work precisely the same way, but there's some excitement about the fact that some of these injectable medicines can be given twice a year. The problem is that when the initial price of these was in the $14,000 range per year. So when you do a cost-benefit analysis, you can see for adjusted quality for quality adjusted life years, which is a standard way that the medical economists look at this, you can see this is way high. This even to get one extra quality life year, you're up in the range of $450,000 per quality life year. When we talk about things that are kind of reasonable, even things like hemodialysis, we're more in the $50,000 to $100,000 extra cost. So these medicines are unfortunately still quite expensive. They have lowered the price to around $6,000 a year, but that is still, the insurance companies do everything they can to prevent you from getting the medicine. And it is a lot easier to get in Europe, I guess I would say that. So I want to conclude just by reminding you of two things. Number one, if in fact you or somebody near you is having suspicious symptoms, heart attack type symptoms, call 911 and you will be transported, especially in New Jersey, to a very good hospital where you can get angioplasty, hopefully within 90 minutes. And again, the other part is the prevention, which certainly as cardiologists, we spend a lot of time working and encouraging people to get better cholesterol levels and get their blood pressure under control. So I think I'm going to stop there and leave, I think, probably a fair amount of time for questions.
Okay, so Larry Cunningham, you get the first question.
Okay. Can you hear me?
Yes.
Yeah, question. When you look at the individual in the 20th century who was probably under the most stress was probably President Eisenhower, given the fact that the amount of smoking and the amount of stress that he was under in terms of preparing for D-Day. What's the correlation between stress and heart attack?
Well, that's a good question. And when I talked the other day to Victor and Paul Tukey and everything, I said, well, giving this presentation is one thing, but I know you guys always have the toughest questions in the world. So this is really the test here to answer some of your questions. Stress has been studied, and I would say it's certainly not good, but it's not up at the very top in terms of things that we can call a risk factor. There are some occasional examples of people under tremendous stress that have a sudden heart attack, but that is not the general problem. And again, some of this is, I'll say, many years in coming, so that somebody like President Eisenhower, I'm sure, had many years, probably in his 50s or even in his 40s, plaque buildup that ended up causing this sudden heart attack. Now, of course, it happened on the golf course, so maybe he did have stress on the golf course, but I don't think that is the critical factor.
No, well, he was a pretty heavy chain smoker for most of his life. But
I think he was. I don't have that right in front of me, but I think he was.
It's like 70 to 80 cigarettes a day. It's just like constant. So.
Yeah, well, that definitely does. I mean, that for the people we see that are 40 or 50 years old that come in with a big heart attack, there's virtually two things. One is cigarette smoking, and also moderate or high cholesterol. That's a bad combination. So we definitely see that in the people that have early coronary trouble. I also, when you mention Eisenhower, I want to say that I ended up, when I was at Walter Reed for a couple of years, I ended up taking care of Mamie Eisenhower. She had some serious heart problems, and she was in her 80s at the time, but a delightful woman. So I guess that's my claim to presidential fame as far as being somewhat connected.
Mm-hmm.
One last quick follow-up. So the actual smoking itself, is that what contributes to the plaque buildup and that's what causes it, or is there some other?
Well, again, that's a good question. It's both things. The cigarettes and tobacco, for one thing, cause vasoconstriction. So there clearly are people that have underlying blockages let's say it's 70 or 80%, who you can literally see the effect of the cigarette causing vasoconstriction and, worsening stenosis. That is, as you may also know, the other part of the body that gets a lot of vascular disease is the legs, claudication in the legs. And the vascular surgeons, most of their patients, the first thing they tell them is stop smoking. It is absolutely a devastating combination to have coronary vascular disease or peripheral vascular disease that in the setting of cigarettes.
Thank you. Your talk was very good. Thank you. Appreciate
Oh,
it.
thanks very much, Larry.
Thank you. So next, Joe Geist.
Yes, Doctor, I have maybe an unusual question for you, but I've always been told that you should go to Overlook Hospital, I think it is, if you have a heart attack, and Morristown if you have a stroke. Is that correct? What is the difference, or is that just a fallacy?
Well, actually, I'm not sure I would put it that way. Both hospitals, I would say, are absolutely top-notch, and this is proven on all the different ratings things, both not only in New Jersey, but even nationwide. Actually, Overlook is more involved in terms of what I'll call aggressive neurointervention for stroke than Morristown is. So I live here in Summit, and we actually, they have helicopters coming in, but must be once a week, from other hospitals in New Jersey with people that are having a stroke. And these are people that then are taken straight to the angiography suite, and the neurointerventionalists, the neurosurgeons and neurointerventionalists do stroke intervention at Overlook Hospital. So Overlook is definitely, I'll say, the leading center, probably in New Jersey, for stroke, for acute stroke. Morristown is certainly a good place, but now as far as heart attack, both are very excellent, and it really comes down to what is closest. Time is important. So I guess if you live in Chatham and you're halfway between, usually the EMS people know where to go, and they're very good as far as getting you to the right place. So either one would be good for a heart attack.
Okay, thank you. Mark
Okay,
Alon.
thank you.
My question is this. I have a cardiologist. I've had a stress test that came out good. I take a statin, but nobody can tell me whether I have a percentage of blockage. I mean, nobody has told me. And a few years ago, I heard a lot about these calcium score tests. And my cardiologist doesn't seem to have a great interest in it. So the question is, are there diagnostic tools that really tell you in advance of an incident how much blockage you have, and should there be more testing using those tools?
Very good question, and there are some answers. I'm a big fan of calcium score, but that predominantly ends up being good for people that are in the, I'll say, 50 to 60 age bracket. Certainly if somebody is 70 and they're not sure if they want to take a statin, they get a calcium score and it's abnormal, I can tell you what happens. They come running to us, literally. They want to get on the statin as soon as they get the result of the calcium score. So calcium score is a great way to identify people that have early, moderate, or even severe plaque in the coronary arteries. And like I said, if people have had an abnormal calcium score, they become extremely motivated to take a statin or to take whatever other medicine is needed. What you're asking about, though, in terms of what we call asymptomatic coronary disease is very key. And even, I'll put it this way, even if you were to have a coronary angiogram, either a regular cardiac cath or what we call a coronary CT angiogram, which in today's world is pretty darn accurate. Let's say the results come back and you have several 70% blockages. You wouldn't do anything different as long as you're asymptomatic. Even if you had 80% blockages or 90% blockages, you would still be better off on, quote, medical therapy. Now, medical therapy means controlling the blood pressure, weight, no smoking, aggressive treatment of cholesterol. It is only if you have new symptoms, specifically of chest pain or something else dramatic like that, that you fall into a category, what we call unstable angina or acute coronary syndrome. That then puts you in a totally different category. And those symptoms mean that you then fall into a group where angioplasty and stent or even bypass may be indicated. If you're asymptomatic, there's virtually no great indication for angioplasty and stent, or for that matter, bypass surgery. There are some exceptions, but that certainly is the key part, is asymptomatic with coronary disease versus symptomatic with chest pain and angina.
Thank you.
Does that help answer your question?
I think so. He's muted now. So at this point, it's 11:32. So let me ask Bob, can you stay longer?
Oh, sure.
Okay, so let's keep going. We have a lot of hands raised. We can't go all day, but so try to keep your questions short if you can. And Steve Varley, you're up.
Bob, first, thank you for a wonderful talk today. And more importantly, thank you for all those years you took such great care of me until you were so bold as to three-quarter retire.
Thank you, Steve.
Here's my question. Back in the day, if you suspected you might have a heart attack, you called 911. The advice was take a full adult aspirin, chew it. Is that still the right protocol in an angioplasty world?
Yes, it is. And if you don't take it at home, you're going to get it in the emergency room, and you're also going to get heparin and some other, in essence, clot-dissolving medicines or antiplatelet medicines that are way stronger than aspirin, certainly for the first several days. And you're probably going to go home after your heart attack on aspirin plus antiplatelet medicine like Plavix or Brilinta. Now, certainly if you have an angioplasty and stent, you're going to be on those medicines for roughly 6 months, sometimes less, sometimes more. Then let's say at 6 months, you might be able to stop the Plavix or Brilinta and stay on just a baby aspirin alone.
Thank you.
Okay. Alejo, you have to unmute.
Oh,
There.
Dr. Slama, thank you very much for a informative, wonderful, and very nice talk that was easy to follow. Many
Good.
medical talks use terminology that totally blows me. I may be asking you one of the tougher questions, but I've often wondered, has the medical profession ever defined an ideal cause of death? That you lead an active, healthy life, and then you have a quick, sudden death so you don't become paralyzed or a burden to your family. I haven't seen any such ideal causes. Do you know of any?
Well, no, I don't. And that this sounds like more of a question for the bioethics committee. But, you know, there's an old expression that pneumonia and renal failure are the friend of the elderly, because those can, especially in the prior days, renal failure was fatal and pneumonia was relatively quick, especially in the days before good antibiotics. But no, I don't have, I'm not that sophisticated to be able to give you a good answer to a nice way to go, a quick way, but I know what you mean.
Thank you.
Next is Ron Weinger.
Oh, yes, hello. Considering that you can't keep calling 911 day after day after day, how do you know if, or how do you suspect you may be having a heart attack versus some other kind of chest pain? And what is the best advice for somebody who's living alone to handle all this?
Ron, the two things I would say is, one is the type of symptoms. One is just the general severity. Men, men tend to be what we call deniers, so that they will sit and say, "Oh, I had this elephant on my chest, but I don't know what. Maybe I may have had some pizza or something." But the location, it would be important in terms of somewhere in the chest area, somewhere epigastric, just above the belly button up to the chest, sometimes in the left arm, sometimes in the right arm. It tends, at least, to be unusually, I'll say, severe. It's not something that you say, "Oh, I've had that before." Most of the people that have heart attack have pretty dramatic, it's something that gets their attention. Now, to make, I'll say, your question even a little tougher, women, for reasons no one really understands, women have even harder to interpret symptoms of heart attack. They're more likely to describe shortness of breath as opposed to chest pain. So you're absolutely right that you don't want to feel like you're calling 911 all the time. But the other thing that we are always that is the first question we ask somebody when we're talking about chest pain is, if you are having any type of chest pain that occurs when you're walking up a hill or doing some type of heavier exertion, and you get any type of discomfort, whether it's in the middle, left, right, up, down, whatever, if it's related to exercise or activity, that is very suspicious that it's cardiac. So that's one of the things that we always remind people. If you are starting to have coronary trouble, you're going to very often know it before we do, because you're going to be out walking the dog or out, going up a hill and doing something that normally would not cause any symptoms, but all of a sudden you get new symptoms associated with exercise. And typically, if you stop exercising, it goes away within a couple minutes. That would be a red flag. So if that happens, call your doctor. You don't necessarily have to call 911, but call your doctor.
That's very good to know. Alan Chenoweth.
Yes, what you just mentioned was exactly what happened to me, that I suddenly got an angina attack. This was back in 1979, and then thanks to your old colleague Tom Inglesby, that led to me having a bypass operation carried out by Dr. McVaugh in Lankenau Hospital, Philadelphia. And I was interested in your remark that being an aviator or a pilot or a cardiologist, those two professions don't mix. And but I was told at the time that Dr. McVaugh had recently been in the program for training as astronauts, and he'd left the Air Force, but he owned his own Learjet. Is that true? I'm not sure.
Well, it is actually true, and Dr. McVaugh was somebody we all knew, and back in the day, that was a good place to send people to. I'll say, fortunately for everybody in New Jersey, we don't have to send people out of state anymore. But Dr. McVaugh would fly to Paris on his Learjet and have dinner with his wife and then fly back. So he was quite the high roller and charming guy.
Yeah. Well, he certainly did
an
a
excellent
good job
surgeon.
on me.
An excellent surgeon. Yes, I agree.
Ed Atkin.
Okay, it was a great presentation. By the way, my optometrist was a 4-star treated Eisenhower when he was in the military. But my question, I had a virus cardiomyopathy in 2018. I had a bad reaction to prednisone and was bloated with fluid. First, they told me heart ejection was 16, then 23, and then it improved substantially. It had to go above 30, went to 38. And what, I also had I guess, a catheterization done by Dr. Giuliano, no blockage, no plaque, no stent. My question is, does swimming help quite a bit improve your heart ejection rates?
Well, your ejection fraction,
Right.
I wish I could say yes, because exercise is certainly good for people that have cardiac problems or cardiomyopathy. So it helps you overall, but it doesn't actually change your ejection fraction. So the primary benefit when you look at most of the cardiac studies with exercise is that people tend to be able to lose a little weight with exercise, and even 5 or 10 or 15 pounds weight loss helps virtually all cardiac problems. But no, it does not actually raise your ejection. Exercise or swimming doesn't actually raise your ejection fraction.
Okay. Next
But keep up your exercise.
What happened to PCW? Oh, PCW. Who is that?
Me. It's
You're
me.
Me,
Bill
I don't
Tittle.
know who's. Oh, Bill Tittle. Right.
Yeah, thanks. Great talk. I have a sweet tooth and weakness for imbibing sugar. Well, no, not sugar, chocolate. And I love these articles that say chocolate is actually good for you. Is chocolate positive, neutral, negative for people with a heart condition? I've got 3 stents. I've had a heart attack.
Well, I happen to like chocolate, and I can give you, there's some data that is chocolate, quote, is good for you. My problem, and this is just personal experience even in the past month or two, if I open up a jar of peanut M&Ms that are really good, I can't stop eating them. So I just going cold turkey as far as chocolate right now. So as far as data that shows that it's good for you, I'd say maybe, but I just think and I think if you can have limited amount of chocolate, it's fine, but it's not one of the things we put on the diet list. The ones that I think are important are kind of less meat. I think most of us have started to decrease the amount of red meat in our diet, more fish, more vegetables, more fruit. I'm in a thing now with avocados that I didn't used to eat, but I think they're great. And even mixed nuts, more nuts and more vegetables and stuff like that.
That's great. Thanks. Marcel, Simone, or Simon?
Simon, good morning.
Thank you.
Thank you. Very informative talk, Doc.
Thank you.
So I have an abnormal EKG. It's been like that for at least 35 years since I had my first EKG. And so far as I can tell, I was born this way. One of the waves is inverted or something, okay? The point is that doctors who don't know this during various, medical tests have sort of semi-freaked out when they've seen it until, they told me. And then I said, well, yeah, here is some history of EKGs that shows that this is kind of the way I am. Now that I'm getting older and therefore my risk of, cardiac disease is increasing, what would be an effective way of notifying EMS folks and emergency room folks in case, God forbid, I kind of, get taken to the hospital with a possible, coronary thing that I have this condition and please don't go make decisions based on it, because that might not be, good medical practice.
Well, we in the situation you're talking about, we often, this again is people that have an abnormal EKG that would be suspicious for a heart attack or something like that. We literally tell people, make a Xerox copy and keep it in your back pocket or keep it in your purse or wallet, because it, just like you're describing, if you show up in an emergency room with some abnormalities that are chronic on an EKG, they get a lot of attention. And what the doctor in the emergency room is forced to do is sort of act as if it could be a heart attack, let's say. So that if the prior EKG shows similar changes, that's very, very reassuring. It doesn't answer the question 100%, but it certainly is reassuring that the EKG abnormality is not new, that it's old. The type of ST elevation that I'm talking about today is pretty dramatic. And I don't know what abnormality you have had on your EKG, but the ST segment elevation is quite specific for a STEMI heart attack.
Thank you. Okay,
Sure.
Marv Pincus.
Thank you. I'm sure there are some people on this call, like myself, who have partial artery blockage and have been given amlopidine and metropolo as an alternative to angioplasty. What's your feeling on having that medicine along with statin to help out instead of having angioplasty or bypass?
Again, very good question. There is, as you probably know, there is a ton of data on that. And that's why I said on one of the previous questions, if you are asymptomatic, no chest pain, no change in your angina symptoms, you have what we call stable angina. And in that case, and I'm not sure, you didn't really say you have angina, but you can have pretty severe blockages. And the data absolutely is reassuring that if you are on full medical therapy, which includes some of the medicines you're talking about, your prognosis on medical therapy is as good or better than angioplasty and stent. Now, again, that starts to change. There are certain categories that could change that somewhat, but if you're doing well, active, able to do a fair amount with either no symptoms or limited chest pain symptoms, you can be that way for years and years and years. And the only thing that would really change in terms of what to do differently would be if you have what we call either unstable angina, or the other term we use is ACS, acute coronary syndrome, which means that everything is changed. The EKG might look different, your chest pain pattern is different, you might have small enzyme abnormality indicative of some early heart damage. That would change everything. And then the decision about bypass or angioplasty is totally different than what you're describing right now.
Thank you. Well, we're really running out of time, so I guess the next question will be the last one. More hands are still going up. We could go on all day. But anyway, I'm very pleased to see Bill Hageman on the call. He's a member, doesn't come too often. Welcome. And I think you spent your career doing drug development at Merck, so you probably have some incisive thing to say.
Yeah, actually, yes. Thank you for the very interesting presentation. I was wondering if you could comment on the role of vascular inflammation in heart disease and whether or not statins actually address that.
The vascular inflammation, what you're also talking about is the so-called pleiotropic effects of statins. And I'm certainly, I can't disagree with that, but the primary benefit of statins is that it lowers cholesterol. And if you compare other ways of lowering cholesterol other than statins, like I said, the prior ileal bypass, which no one does anymore, or other totally non-statin medicines that are effectively lower cholesterol, they also have what we call an anti-inflammatory effect just by lowering your cholesterol. So I am not a huge believer in the anti-inflammatory or pleiotropic effects of statins. Just as an added part of that, when people talk about high CRP, elevated C-reactive protein, that correlates extremely well with obesity. People that are obese have a high CRP. So there's a lot of overlap in terms of cause and effect and what you're really treating. So yes, if you have high CRP, I would, and that's, you're not specifically asking, do you have high CRP? But if you were, I'd say, fine, lose weight, take a statin or take whatever other medicine you can to lower your cholesterol.
Okay. Good. Thank you.
Okay.
So Vic Rosenberg, back to you.
And you guys brought us Mevacor, by the way.
Yes, among others.
Dr. Bob, I think your talk today, given the average age of our organization, may actually be a lifesaver. And I want to personally thank you for your excellence in your presentation. And on behalf of the old guard, there are two ways to thank our guest speakers. The first way is with this certificate of appreciation, and the red orchid in the lower left is an indication that Summit was a orchid center for many years and has a history of with orchids that's very positive. And the second way the second way we thank you is with something called the Old Guard Salute. Hey! Thank you so much. I look forward to having lunch with you again soon at Finn.
Good, Victor. Thank you very much. It was a pleasure to do it. And again, the group and the questions lived up to their reputation.
Okay, Vic and Dr. Bob, thank you so much. And I know, Dr. Bob, that your good friend Vic has been trying for a while to get you to become a member of the Old Guard. And if you do make that decision, we would just be delighted.
Well, thank you. I would look forward to that, definitely.
Wonderful.